Hello and good afternoon. Welcome to Canon's Collaborative Liver Imaging Seminar. We're very pleased to have you all here. Today, you'll hear how our esteemed clinical colleagues are using Canon Medical's imaging systems and applications to provide accurate visualization and streamlined workflows to help simplify the complexities of liver oncology. Our panel, I'm pleased to say, consists of two clinical professionals who will discuss this comprehensive solution that is delivering a total end-to-end workflow solution and making a difference to routine patient care. I'm privileged to introduce Dr. Surachate Siripongsakun and also Dr. Teoh Chyi. I will provide a more detailed introduction in a short while. I'm Dr. Ravi Shrestha, General Manager and Senior Director of Global Healthcare IT here at Canon Medical Systems Corporation. I hope that you'll enjoy hearing from the panel today that we have assembled here, and please feel free to reserve and save any questions that you have for our live Q&A following the talks. The focus today is on liver imaging solutions, and as a background, born from Canon's Made for Life philosophy, Canon Medical Systems is committed to ensuring that imaging intelligence is embedded in each step of a patient journey, from acquisition to follow-up to deliver patient-centric care and make a difference for patient care. So if we specifically look at hepatic disease treatment, about 700,000 people are diagnosed with liver cancer worldwide every year, as you saw from the beginning video prior to this session opening up. And it is the fourth most common cause of cancer death overall. There is a steady increase in terms of global liver disease treatment market by an astronomical amount of 11% compound annual growth rate, and is expected to reach $20.1 billion globally. So in that context, if you look at liver disease progression, there is a prevalence of increased prevalence in terms of rate of obesity. So this is a 21st century disease problem, and it affects about 25% of the global population. Liver fibrosis, if caught at an early stage, is asymptomatic, but it may lower patient life expectancy in the late stages, especially when cirrhosis occurs. So that's why early detection and treatment for hepatitis and fatty liver allows us the opportunity to reverse the deterioration. So in patient management for liver, early detection is key. So with regard to that background, looking at the liver disease progression, we know that the liver tissue damage leads to liver failure or cancer development. And the evaluation of cancer is very complex, as we know. And we must organize many modalities and diagnostic solutions, as you can see from the collaborative imaging chart that is in front of you. So to simplify this and to tackle the complexity of diagnosis and treating the multifaceted liver disease, clinicians need integrated, intelligent tools. Collaborative imaging from Canon Medical Systems delivers a complete imaging solution end-to-end in terms of the whole disease progression, using the ultrasound equipments that will be conveyed in this presentation, including attenuation imaging, shear wave depression, and shear wave elastography, plus plethora of different solutions, including the Colin-1 system with its breadth of different tools. So collaborative imaging essentially allows these tools to be joined together so that we can see the whole patient picture. No matter whether it's a single modality or many modalities, collaborative imaging can provide the ability to navigate the patient care process completely. We offer a very broad and unique range of portfolio, spanning from evaluation of ultrasound and CT technologies to angio systems for intravascular treatment, as well as advanced visualization systems for precise and efficient treatment planning. So joining us first in terms of the presentation, I have the privilege to invite Dr. Surachate Siripongsakun from Chulabhorn Cancer Center. Dr. Pao, as he is known, hails from Udon Thani province in Thailand and is attached to the Department of Diagnostic Radiology at Chulabhorn Hospital Cancer Center, including serving as the head of department for 5 years from 2013 to 2017. Dr. Pao is a seasoned lecturer in liver oncology and imaging within Asia and globally. He has directed a number of ultrasound workshops and is a director and key faculty member of the Sonographer School Faculty of Health Science Technology at the Princess Chulabhorn College of Medical Science. Dr. Teoh will provide an overview and highlight how Canon and the Sonographer School have partnered together to transform patient care with the power of collaborative imaging liver imaging tools. Specifically, Dr. Teoh will elaborate the non-invasive ultrasound imaging technologies that enables characterization of liver lesions for confident liver assessment. Dr. Teoh, over to you.
Thank you so much. Can you hear me? Dr. Ravi, thank you so much for your presentation. Let me share my slide. So thank you again for Canon Asia for inviting me for sharing my experience on using the Canon platform, ultrasound platform, to look at further pathology of the liver. So today my talk is role of the 3 application add-on of ultrasound for evaluating liver pathology, which include SMI, superb microvascular imaging, shear wave elastography, and attenuation imaging. These are applications that add on for the classic ultrasound. Let's begin with the presentation. So start with the SMI. SMI is superb microvascular imaging. Let's look at the theory and then the technique behind. If you see the color Doppler technique, so when we select the information from the vascular, the movement, we use Doppler shift track technique. But the thing is, the system will eliminate the clutter or noise of the motion of the tissue during the vascular pulsation. So the machine will clutter out using the Doppler filter or wall filter out. So every slow flow is eliminated. So we see the image of the significant vascular flow. So how SMI is doing? SMI is more selective to remove the clutter, only the clutter, and preserve the slow flow of the vascular flow. So for imaging, we can see further small vessel because of the slow flow is not eliminated by the filter of the SMI. So how we apply for clinical practice? This is an example of SMI in the liver renal parenchyma. You can see the microvascular structures inside and also outline out the normal structure here, including the true cortex and the medulla. So we can be sure what is what inside the normal structure as well. So with this technique, I would like to suggest you to use in add-on of the benefit to get from SMI. In my clinical practice, I use SMI for the mass detection using the vascular displacement. If you see normal vessels inside, you can make sure that it's normal. If you have mass, the mass often displace or distort the vessel. The mass effect can be detected on SMI. So, and the second one is distinguish between true lesion and pseudo lesion. Especially in the liver, we deal with a focal fat sparing, which always are hypoechoic. So we sometimes come as a nodular type, so it's difficult. SMI can play a role in this entity as well, in my experience. And also we can use vascular pattern, flow pattern to maybe help distinguish some of the specific one like hemangioma and FNH. I will show you some clinical cases to make understand of this. So the first case is a patient with cirrhosis and come for surveillance of HCC. We see the cirrhotic change of the liver, but we would like to see every single parenchyma, every scan, the whole volume of the liver. But sometimes there's some of the hidden area. So I always use SMI to see the inside the vascular structure. If it has vascular structure everywhere like this, I feel comfortable that there's no big mass or infiltrative lesion inside the liver of these cirrhotic patients. So it's make me more confident of screening of ultrasound. So this is an extreme case of the patient. Patient come with the surveillance as well. On B mode, we don't see anything much, only subtle subcapsular retraction here, and see some of ill-defined thing like this. We don't sure because it is so iso. So we use SMI to see is something behind, hidden behind or not. This is the SMI that we see. We see the distortion of the vessel. The vessel is wrapped around the lesions. So this is a sign of mass lesion because it's spraying of the normal vessel out. Patient undergo MRI. It turns out to be FNH. It's around 8 centimeter, but the B mode grayscale ultrasound cannot detect well. So SMI is helpful in confirming this is a true lesions. The other one, this is the example of the hemangiomas. Hemangiomas will show on SMI, will show ring pattern with nodular flow like this, peripheral nodular flow with the ring pattern like this. This is kind of typical for the hemangiomas. If we see like this, I will more comfortable like follow up the patient. It's true nodule, but this one is not early, just we can select for the follow-up. No need to go to CT and MRI immediately. This is can wait. So for the lesion that we need to focus is for HCC. For the small HCC, this is an example of the case. This is the hypoechoic lesion inside near the gallbladder fossa, which is the area of a common for the focal fat sparing. So we would like to make sure this is not the HCC or focal fat sparing. We have to make sure. I just used SMI to look at it. If we see inside the nodule, there is a enhancement, the flow inside the lesion like this here. So there's a feeding arteries, feeding vessel inside the nodule, which is favor for two nodules. So we go on for the MRI. This is MRI showing this is have arterial and venous washout. This is confirmed to be small HCC. So SMI can play roles in order to make sure it is a true nodules or focal fat sparing. So in this case, it's a small HCC. It's very helpful for me. So in the other case, for the typical of the flow pattern of SMI, this one is a hypoechoic nodule. So if we use the SMI, we see the spoke wheel pattern of the nodule. This is a typical one for the FNH or focal nodular hyperplasia. So this one again is quite typical of the flow pattern. So this case is not hurry. We can go to confirm with MRI later. So in this case, we confirm with MRI, it's confirmed to be FNH with a typical enhancement on SMI as a spoke wheel pattern. So in conclusion, for the SMI, it's an add-on application. We can use SMI for the mass detection and distinguish between pseudo or true nodule lesion. And also the special add-on in some vascular pattern, we can can call hemangioma and FNH. This is the add-on, the first application of SMI. And the second application for the ultrasound liver is the attenuation imaging. It's the mode for the measure of the fat inside the liver. So the principle of the ATI is that if you have fatty liver, the fat content will have attenuation of the sound beam. So the more sound penetrate past to the fatty liver, it the weaken of the sound. So the pattern is inverse square law. The more deeper of the sound penetrate, the intensity is dropped inverse square law a lot. So the machine will calculate if the attenuation is coefficient is strong. That means there's a lot of fatty liver. If the attenuation is coefficient is mild or small, is less fatty liver. something like that. But the machine have to calculate control the confounding factor of the focus and the gain control to make it more linearity and calculate for the attenuation coefficient to make it stable to measure as a constant value. So this is the example of the measurement. You just open the mode, ATI mode, and then measure in the box of the yellow box like this, and then got measurement. So it's easy to perform as well. So how is the performance of the ATI? There's a paper published by the Ferrarioli, the expert in Italy group. They compare the ATI and the CAP. CAP is a control attenuation parameter. It is a mode in the FibroScan machine as well with the same principle of ultrasound attenuation. They found that they correlate with the gold standard of MR proton density fat fraction using the Dixon technique of MRI to use in-phase or post-phase and calculate the percentage of fat to make us a standard. So they found that the ATI has a high correlation to the MR technique compared with the CAP method. CAP method is a good correlation, but ATI is a higher correlation. So I will give some example how to use the ATI in clinical practice. So normally we look at the visual scale of the bright score, something like this. We compare liver parenchyma to the kidney cortex. If it's equal or just equal, it's no fatty liver. Like this case, the bright score is 0, no fatty liver, or less than 5% of fat. So we do the ATI. ATI for the cutoff of the mild fatty liver is 0.6. This one is a 0.5, so no fatty liver. So we confirm with the MRI. MRI PDFF is less than 5%. It corresponds well with the normal liver. So this is example of the mild fatty liver from B mode. B mode, you can see the mild fatty liver comparing the renal cortex. So ATI with measurement is 0.69, which is fall into mild fatty liver S1. So for the MRPDFF is around 10% of the fatty liver, which is correspond to mild fatty liver. It's go along with each other. So how about the significant fatty liver? This one is moderate. You can see the grayscale is not that good because of high fatty liver, and this is obviously significant fatty liver on B mode. So for the ATI measure 1.1 coefficient, which is more than S2, more than moderate fatty liver. So this one confirmed with the MRPDFF is around 20% of fat inside using the MR technique, which consider the significant fatty liver. So for the ATI technique, I think it's a add-on application that used to quantify and monitor of the fatty liver, and it has good moderate to good correlation with MRI, which is good. And patient can be one-stop service. Let's say come for surveillance and quantify for fat. And next time we can monitor the fatty liver in the clinic. It's one-stop service. So I will bring you to the last one of shear wave elastography, which can be equipped in the ultrasound machines. So I will bring you to background first. What is a shear wave? Shear wave is different set of ultrasound beam. Normally we use sound beam for B mode is a longitudinal wave, which is very high frequency. The longitudinal wave will transmit through the media without having the lateral shear wave, just go penetrate directly. And the speed is very high. But shear wave is much lower in frequency less than 1000 Hertz. So when they pass to the medium, they have tissue motion that have lateral wave as well. The lateral wave is called shear wave that has less than 10 meters per second for the velocity. So the shear wave or lateral wave is like this. When you use shear wave, penetrate down and it will check the media and it have create the lateral wave like this. The velocity of the lateral wave can be high correlate with the stiffness of the medium. I mean, if the medium is very stiff, the lateral wave will be faster, something like that. So we use this property to calculate the elasticity of the tissue, like liver. Like the number is the E or kilopascal. It's correlate with the V is the lateral wave that I showed you earlier, power by 2. So there's a modality that can measure in clinic, like fibroscan, use the same technique of the mechanical wave like shear wave, and it calculates the velocity of the sound beam that pass through the liver parenchyma. And in order to use, it's easy. You just measure and it's come with the number like this. And the point is how to interpret which is which. What this number translate to clinical practice. In the fibroscan, they have a scale. In different hepatitis pathology like Hep B, Hep C, or fatty liver, alcoholic fatty liver, something like that, is a different cutoff. And they have the scale because they have lots of research ongoing, something like that. So if we measure like this case is 3.9, you just see the scale of 3.9. And then if you are in hepatitis patient, it's in the green one is no fibrosis, something like that. And then different cutoff of Hep B and Hep C because different pathology, something like that. And how we translate into the shear wave interpretations. In shear wave, we can see modern fibroscan. We can see the anatomy inside and select the good area to measure. For Canon, they have a propagation map to select the good representative area to measure, something like that. So normally we measure like 10 times and evaluate using median and SD and IQR. So how to interpret the cutoff? There's some meta-analysis using shear wave elastography and proven with the biopsy. I would like you to remember two cutoff. One is the fibrosis stage 2. More than 2 is 8. In Asia, we have a lot of Hep B, so it's around 8. And for the cutoff of cirrhosis, it's 11.5. If we use the cutoff 8, that means you have significant fibrosis. It's in the stage of maybe the patient need treatment to reverse the fibrosis back to normal liver. It can be doable for the medications. And the cutoff 11.5 is for cirrhosis. If you see the cutoff of 8, you can see it's a very high sensitivity. You can collect all of the patients, but the specificity is only 73. That means 1/4 of the patient get falsely high for the elastography if you use this cutoff. That means if we have a high elastography on ultrasound, maybe we need to reconfirm by another technique, including MRE, MR elastography, or maybe biopsy to confirm before treatment. I will give you some example. This one is a 78 years old male with Hep B hepatitis chronic, and this is MRI before. We see that there's no obvious cirrhosis, yet no splenomegaly, and liver seem homogeneous on MRI. And we perform the ultrasound elastography. So it's come out is 11.9. That means it's fall into cirrhotic range, right? So what to do next? So if you use this cutoff, you have to make sure it's a true, not false positive. This one needs to go to MRE or biopsy to reconfirm. So we go with the MRE. MRE, if more than 3 kilopascal, it's a significant fibrosis. This one has 3.7. This is confirmed to be, I think it should be true positive in this case. In this case, it has a significant fibrosis or early cirrhosis. The patient needs to refer to GI doctor to decide the treatment. So this is the good thing that we know in early, because we can do it in the one stop at the ultrasound clinic in your practice. So in my conclusion, there's a 3 add-on application on liver ultrasound. One is SMI. SMI is useful in order to use as a mass detection, distinguish between two nodule and pseudo lesion, and also some of the vascular pattern will help its diagnosis. For ATI can use as a quantify of the liver fat and also monitoring of the fatty liver after treatment as well. And also shear wave is a non-invasive stiffness measurement. It is potential for hepatic fibrosis staging and cirrhosis evaluation. So that's all my presentation. Thank you very much.
Kakun ka Bachan, thank you,
Krap.
Dr. Pao. We learned a lot today from you. Thank you for the appropriate role of SMI, especially with regard to vascularity and pattern and SWE, and also ATI as well for fat quantification. Next, we're absolutely delighted and pleased to introduce Dr. Teoh Chyi. Dr. Teoh is a senior consultant in the Department of Radiology at Changi General Hospital and the acting assistant professor at the Duke NUS Medical School in Singapore. He is also the department's subspecialty director of ultrasound and a co-faculty member for the Sing Health residency here in Singapore. He received the Eastern Alliance HMDP Fellowship in 2013 and did his clinical research fellowship in liver oncology, ultrasound contrast, and elastography at Hammersmith Hospital in London. Dr. Teoh will be sharing some clinical insight into the novel method of using iodine mapping with a single source CT and subtraction software applied to liver imaging. Dr. Teoh, over to you. Thank you very much.
Very good afternoon. Thank you for joining me today. So today I'm going to talk about the novel technology of iodine mapping for liver lesions. So what is iodine mapping? I think anyone who does CT imaging will know that CT contrast contains iodine. Enhancing tissue and lesions will contain iodine. And so if we take iodine-only images, we realize that these are actually surrogates of contrast uptake. So how are iodine maps usually obtained? So iodine mapping is actually usually obtained from a dual energy or dual source CT system, because what it does is that it relies on the differing absorption properties of iodine at both high and low energy level. So for example, if you look at this chart, you could see that we can use 100 kVp and 140 kVp, two different kinds of energy source, and then we use the difference to say that to quantify the amount of iodine within the lesion. So this is how we actually can generate a tissue iodine map. So here are some clinical examples. You could see that on the image there are perhaps some very small amount of iodine enhancement. Okay, can be difficult to appreciate particularly if you don't enhance this if you don't window the image properly. But if you use an iodine map, okay, the enhancement is a lot more apparent. You could see that the very bright spots, the orange spots, those are enhancement, those are iodine maps, those are positive for iodine. So we know that there's enhancement. So the issues with the dual energy or dual source system, it's actually a hardware. So you actually require a hardware, and you can't really upgrade this from your pre-existing system if you don't have a dual energy or dual source system. And of course, we know it's actually quite expensive to have such a system. And generally, it has to be a pre-planned acquisition. So for example, you actually need to switch on your dual source if you decide to use both the tubes to image the lesion. You can't really decide to do it retrospectively. So the question here we have is, is it actually possible to still obtain iodine mapping with a traditional single energy system? So the answer actually is yes, because actually what we have here is that Canon is doing this with a single energy system by using their shear subtraction software. The principle is actually quite simple. What it does is that it uses a pre-contrast sequence to subtract a pre-contrast sequence to actually obtain a contrast-only image. So as you can see in the graph on the left, what you do basically is you just do a simple subtraction and you can get the iodine map. So here are some examples. Oh yeah, before I go on to that, I just want to explain the trick into doing this properly is actually to have a very good subtraction software. A lot of the challenge in doing subtraction is really because of motion. You need to be able to correct the motion very well. So you can see there's two images here. One is the non-contrast and one's the arterial phase. There's a slight difference in motion, so we try and subtract this. You could see for those of us who've done quite a bit of subtraction imaging, particularly maybe more for MRI imaging, there is a mismatch. So really, this is not a very good image when it comes to subtraction, and this will not work so well if we are trying to do iodine mapping. But what Canon has is that they have the shear subtraction software with deformable registration. So they actually recognizes the points of the patient. So the patient in the patient. So if you subtract it, you could see the subtraction is almost perfect. Okay, there's a successful matching of the anatomical structures. So here we have some more beautiful images courtesy of Canon. You could see that the IOB mapping, the contrast, they're quite nice, okay, and they're very, very conspicuous. So how can iodine mapping help with our evaluation of liver lesions? Number one, we think that lesion conspicuity is much increased, leading to better detection. It's somewhat similar to what Dr. Pao was talking about when he was using the SMI. By using his SMI to make the lesions more conspicuous, iodine mapping to a certain extent also help with this detection. We think that a lesion characterization can be improved because iodine mapping actually allows more confident detection of enhancement. And really, I think the most important thing to us, we think that it's actually quite useful in evaluating viability of liver lesions which has underwent local ablation therapy. So let me share some cases with everyone that we have done clinically so that we can show these points better. My first case is a 76-year-old man. He has a recurrent multifocal HCC with multiple TACE therapy and local ablation. His most recent TACE was performed 6 weeks prior to this scan. So this is a pre-contrast scan. Everyone can see there's some lipidal optic here. And maybe this lesion, a little bit of rim optic. And this is the arterial phase. Now, the reporting radiologist was not so confident. This is not so sure whether there's any contrast optic in this lesion. And I would say that, yes, it's actually quite difficult just by looking at the CT itself. Let's look at the two other phases. Again, they are not really very helpful. We're still not very confident whether there's any contrast optic. So depending on who's interpreting the scan, there may be differing opinions about whether this is still remnant tumor. So let's apply the iodine maps. So what we are doing here on the very left, you could see this is arterial minus non-contrast. This is venous minus non-contrast. And this is delay minus non-contrast. You could see actually there is definite contrast optic. Now, what about the lipoidal stain? You may be asking. Look at this other lesion which has a lipoidal stain. It doesn't light up at all. So you know definitely there's actually contrast optic in the lesion. And you can see as you go through the delay phase, there seems to be a little bit of washout in part of the lesion. So we're quite sure that actually now that this lesion is still viable. Let's move on to my second patient. This is a 52-year-old male patient. Hepatitis B, had recurrent multifocal HCC with previous hepatectomy. He had also underwent TACE, and this is the surveillance CT that is performed 2 months later. So you can see there's a large mass here. There's a lot of lipidal optic. This is a non-contrast. This is the arterial phase. This is the venous phase. And this is the delay phase. If you look at it, we're not so sure now. Is there a little bit of enhancement here? Maybe, and around here? Not exactly sure. So let's take two of these images again, the arterial phase and the non-contrast phase, and then we subtract it. And there you have the iodine map. And look at where there is now some light up. This is where actually there's some contrast optic. Now, compared to where there's some lipidal, you could see there was no optic at all. So we're quite sure there's actually some remnant tumor here. And then this is the delay phase. You could see the contrast actually part of it is actually washing out. So definitely there's remnant tumor in this lesion. And then if we move slightly more inferior to the the more inferior aspect of the liver, you could see there was actually a bit more enhancement in the more inferior aspect. And we go back to the look at CT. Again, it was quite hard to see on the CT on the enhancement depending on your windowing, but definitely this portion in the inferior aspect, there's some remnant tumor. And again, there's some washout that you could appreciate in the delay phase. This is my next patient, 82-year-old gentleman, previous HCC with hepatectomy. He had a new segment 5 lesion that was detected on surveillance, and he had ablation. And of course, as usual, we'll follow up his ablation about 6 weeks later. So this is, as everyone can appreciate, this is the ablation zone. Very clean and neat in the arterial phase, portovenous phase, delay phase. Doesn't look like there's any recurrent tumor, but let's do our due diligence. All right, let's run an iodine map. Okay, you could see the ablation site is very clean. There's no tumor. There's a little bit of enhancement at the site, but that's quite usually expected post ablation perfusional changes. Let me run the whole iodine map once to show everyone. The very same patient. Okay, there's this ablation site. I wonder, did any of you see anything? Let me try and run it again. Concentrate in segment 5, this ablation site, and there you go. I'm just going to slow this down and show this to everyone. Someone saw, one of us actually saw it and said, look, it looks like quite a bit of nodular enhancement in this patch just below the ablation site. So with that, we went back to look at the CT scan. There you go. This is the arterial phase. This is the venous phase. Now, is there washout? If you do some windowing, you would think actually, yeah, there may be some degree of washout. Right. And we put the patient through the MRI, and we're quite sure the lesion is there's actually a new nodule here, just below the ablation site. So what we did in Changi General is that we actually had a small preliminary study of 10 cases retrospectively. So we had 2 abdominal radiologists to read them. One reader actually used the CT images and the iodine map, while the other reader uses the CT images only. And what we do is that we compare this original interpretation with a follow-up CT scan in 3 to 6 months' time, which we'll use as a reference standard. And this is the breakdown of our results. So remember, reader 1 is the gentleman who has, now let me just recall what reader 1 has. Yes, reader 1 is the gentleman who actually had the iodine map. Reader 2 was a gentleman without the iodine map. So you could see that we use LIRADS just to put everyone together. LIRADS 5 usually means definitive tumor. LIRADS 2 means benign. LIRADS 3 is equivocal, but usually more likely to be benign. For LIRADS TR viable and non-TR viable, these are for treatment lesions that are treated. When we say viable, it means that we think there is remnant tumor. When we say non-viable, we think there's there's no more viable tumor. So you could see actually reader 1, the reader with the iodine map actually picked up more definitive, 1 more HCC and 1 more remnant tumor when compared to reader 2. Of course, this is a very small sample size. This is just 10 patients. But when so what we did is that we went back and compared this to reference standard. We found that the reader with the iodine map was actually 93% accurate in identifying and declassifying the liver lesions, for our liver. Reader 2 was actually 68% accurate. So really, the question that we have, and we think is kind of answered, is that will subtraction iodine mapping improve early detection of tumor recurrence after local regional therapy? We think this is really quite useful, and we certainly think that this technique will actually help us detect earlier tumors. And what we have already planned, and we already have the IRB already approved, is that we're going to evaluate 100 patients for the next 2 years. We're going to recruit them. So please do watch this space as we have we get them recruited, and we will analyze it through and see whether iodine mapping has really helped us detect earlier tumors. So in conclusion, IoT mapping with a single source CT using a subtraction software is a new novel method which can be applied in liver imaging. IoT mapping improves the conspicuity of liver lesions, leading to better detection. And we certainly think that IoT mapping can be helpful in evaluation of lesions which had underwent local regional therapy. With that, I end my talk. Thank you very much.
Dr. Teoh, thank you so much for your presentation. The fact that we're doing a continued research with you using our deep intelligence technology and using iodine mapping, which is subtraction for liver imaging, is fantastic. Thank you. Once again, Dr. Pao and Dr. Teoh, we really appreciate your participation today and for sharing how these tools are making a real difference to our partnership and clinical workflow. Within Canon Medical, we specialize and focus on image quality applied appropriately to clinical workflow. And with research that we're doing together, this is our continued innovative focus, and that is fully dependent in terms of our Made for Life philosophy within Canon as well. So next we go into the Q&A session for us. And we've got a few questions that came in through the live Q&A chat. The first of the questions came in from Bangladesh, and it is from a lady called Hasina Afroz. Thank you, Dr. Afroz, for your question. And that's also linked up with another couple of questions that came in with regard to SMI. So the main thrust of the different questions, and this is probably for Dr. Pao, is about how SMI is used in clinical practice, and also how SMI is specifically useful for flow pattern for diagnosis purposes and for HCC. So that's the first tranche of the questions. Dr. Pao, please.
Oh yes. Can you hear me?
Yes, we can.
At first, for the SMI, we use for the lesion detection, because everywhere, if you see the normal vessel, that means nothing there. It's normal. Normal sit in the normal location. If you have mass, the small vessel will be displaced or abnormal. Let's say like cancer have abnormal vessel, so it's distinguished between normal area, something like that. This is the first one. So if we see nodule on B mode, like let's say hypoechoic lesion, so you don't sure it is a true nodule or focal fat sparing, you just put the SMI. If you see abnormal vessels or displacement of the vessel, that means you're dealing with a true lesion, true nodule. The focal fat sparing normally do not have abnormal vessels or displaced vessel, but the area of not focal fat sparing will have decreased vascularity because less fat deposit. That means no less vascularity feeding in that area. That's it. But sometimes please be aware that if you cannot detect the flow, that means it can be pseudo lesion or technical cannot detect the flow. Just let's say if you have deep lesion, the Doppler signal is weak. It's also limitation of SMI as well. So in clinical practice, if you have abnormal vessel, it helps. But if you cannot detect the flow, it can be under-detectable or pseudo lesion. That means non-specific for me. I don't interpret that. So if it's positive, it helps in my opinion. The second one, for the lesion characterization, for the publication, it's quite typical for hemangiomas that we have a ring with dot flow like this. I'll show you my case in my here. You see. Okay. This is a case of hemangiomas. So we see the rim vascularity with the dot like here, representing the slow flow, peripheral slow flow, something like this. This is quite typical for hemangioma. We do not observe in other nodules, something like that. So again, we need to maybe have a solid document about this. like confirmed in many further research, but in our experience and prelim data, it's quite useful and specific for hemangioma. So in my usage, I use this as a more confident that in this case, I just follow up the patient with ultrasound first. Do not need to hurry to MRI, something like that. And the other one is FNH, is a spoke wheel patterns. So we have to correlate with the patient's risk factor as well. If you have spoke wheel pattern and we have a young female, something like this setting, I think it's quite good for FNH and it can be follow up, something like that. And the other setting, if you have a high risk for HCC, I think imaging is still needed, like MRI or CT. I think that's it for my experience.
Sure. Thank you for that. In terms of the request from Dr. Afroch, we'll definitely send you some papers as you've requested on SMI. So we'll make sure that you'll have that to hand, and hopefully that'll make a difference to your clinical practice. There was another ultrasound question as well in terms of looking at the benefits of using SWE in ultrasound. So there were keen interest in terms of elastography, and what were the key benefits that you saw with regard to clinical practice?
So in clinical practice, normally GI Society using the FibroScan because the reimbursement. And we also have problem with FibroScan. It can be falsely high as well as SWE, and sometimes it's cannot operate well because it takes time. You have to measure like lots of time, and I can say we don't see the imaging underlying the measurement, and also we have problem with the obese patients. You have to buy dedicated the probe for the XL patients as well. So, and the cost of the machine is equal to ultrasound machines. So I think for the investment, if you use ultrasound and equip the SWE, it's more cost effectiveness in order to measure. And then the cutoff is ready for us to interpret. So I think the trend is towards shear wave elastography in terms of measurement. Right.
Thank you. We also got one question related to CT, and there was a lot of interest in terms of the iodine mapping and a discussion about that. So the key thrust of the two questions that we had was, what is the main difference in terms of iodine mapping with subtraction scan and with dual energy compared to what you're doing today? So that is the thrust of the question. Dr. Teoh, please.
Okay, actually, the traditional way of doing iodine mapping, as I was trying to explain, was to use a dual source, because the absorption and attenuation of iodine is slightly different depending on the kV of the X-ray tube that you're using, and the difference will actually give you the amount of iodine that is containing in a lesion. That is to say, the amount of contrast the lesion has. What Canon tries to do here with the subtraction is actually a very simple method. If you think about it, it's no different from doing, let's say, digital subtraction of when you're doing angiogram. So they have a pre-contrast and have a post-contrast. They try and match the images together by doing a very good motion correction, and then they just subtract it. So whatever you get is basically pure iodine. Now, the good thing about this is that you can actually, this is actually software. Unlike your dual source, you actually have to buy the hardware, which means you actually have to buy the CT machine, which has dual energy sources. Okay, I mean, there are various ways of doing it. There's the dual source image, there's dual energy. One company actually has a different attenuation absorption based on its detectors. But for most intents and purposes, if you want to do iodine mapping, you actually have to plan for it first, meaning you actually have to switch on your source to image the lesion. But for the Canon solution, you do not need to do that because it's actually a software. So you can use the software to actually subtract it as long as you have your pre-contrast image and the post-contrast image, you can use that to subtract each other and you can actually get your iodine map. So I think that's one big advantage. And of course, cost is always more expensive to have 2 tubes than 1 tube. I think everyone can understand that very easily.
Yes, indeed. And in fact, the next question that came up was is linked to both the cost and the use of this. Specifically, the question was, and it's funny, when we look at the audience today, it's quite diverse all across Asia, and cost is a big factor. So the question was, is iodine mapping, it seems to be a feature that's available only in very advanced high-end CT scanners. The question is it also available to entry-level CT scans?
Oh, I think this, from what I understand when I was speaking to our colleagues from Canon, I was told that it's actually available in even the 16 slice system. So I think if you're really interested in iodine mapping and you want to know whether this is compatible with your coexisting Canon system, please speak to your app spec. They will be able to give you that advice, because this is software. So as long as I believe you have compatible software, it's much easier than to install a whole new CT machine.
Right. Absolutely. Thank you.